Okay, so we are live. Let me know who is in. Please let me know your name in the chat box. This way we can have a better interaction. Okay, so it seems that we start to be present. Please let me know in the chat box your name. And this way we can interact. Okay, we are growing, we are free live right now. So let me know your names. This way we can have an interaction. 4, okay. Hello, Lucas. Okay. Any other attendants? I see that we are 4, so please let us know your name in the chat box. We are 5, okay. Please, 6. Okay, so everyone who's online, let us know your name in the chat box. This way we can have an interactive course and not a passive solution to the questions. So we have Megan and Kainat. Hi, pleased to meet you. Any other students? I think we are 3 more. So Dr. Deep, okay. Hi, Deep. Please let me know your name and we can start right away. So Deep, Kainat, Megan, if I do not read the name correctly, please let me know. Okay. I see that we are more than 4. Please let me know your name. This is the last shout out before we begin. Okay, then let us start. So we have a woman of 35 years that comes for the results of an endometrial biopsy. She was previously diagnosed with high squamous intralesional cancer. The results shows a SIN type 1. What is the best next step? We do a loop electrosurgical excision procedure. We do co-testing at 12 months. We do co-testing at 12 and 24 months, or we do colposcopy. Please let me know your answers in the chat box. Okay, so we have up to 2 votes. Any other votes? Dr. Deepak, Megan, Kainat. Please vote your answer. Okay, so we have 2 Ds and 2 As, or 1 D and 2 Ds and 1 A. Okay. Now, most of you went for D, which is a colposcopy, and we had an A. So let us see what is the answer and how to interpret each choice. Firstly, the answer is C. We do 12 and 24 months co-testing. The patient right now has scene 1 with a previous HCL. The indication for this type of tumor, scene 1, cervical intraepithelial neoplasia type 1, is co-testing at 12 and 24 months if the woman has more than 30 years. However, if the patient would have had a scene 1 with previous LCL or atypical squamous cells of undetermined significance, then we will do a co-testing only at 12 months. We would do a loop electrosurgical excision procedure if the patient had a scene 2 or a scene 3. As we talked previously, co-testing at 12 months is largely for a scene 1 with previous low squamous intraepithelial lesion or atypical squamous cells of undetermined significance. And lastly, colposcopy is the next step if the patient on co-testing had an HPV positive test. Now, in order to have a better understanding, we have this recap. So how we treat actually cervical intraepithelial neoplasia. This scheme will help you to better answer any NBME type question on this type of treatment. So if we have a cervical intraepithelial neoplasia of type 1, the first question we ask is what was the previous lesion? Was it a low squamous intraepithelial lesion or atypical cells of undetermined significance, or was it a high-grade squamous intraepithelial lesion with atypical squamous cells that are highly neoplastic? Then we follow up with co-testing at 12 months for LCL, as we talked before, and at 12 and 24 months for HCL. Now, the results to co-testing can be an HPV negative in the case in which we go back to routine screening if we have LCL or HCL, it doesn't matter. If, as we talked before, the HPV is positive, then we go for colposcopy. On the other hand, if the patient has a high squamous intraepithelial lesion, not only that we need an HPV positive test, but the patient has also an abnormal cytology other than HCL. If the patient has HCL, then we do a diagnostic excision. Again, the diagnostic excision is important to be done after the co-testing at 12 or 24 months. However, if the patient has less than 30 years, we opt for cytology instead of co-testing. Okay, let's take a break and see if we have any questions up until now. Megan, Dr. Deepak, Lucas. So Megan, Kainat, Dr. Deepak, let me know if everything is clear up until now. Okay, now let's go to scene type 2 and type 3. As Dr. Deepak actually said, we do an excision, which can be a leap, or we can do an ablation, such as cryoablation or laser ablation. In young women, however, we can monitor at 6 and 12 months with colposcopy. Again, this is the 30-year landmark, or in other guidelines you might find 21 to 24 years. This is important based on the question bank that you use. Okay, so here we end with cervical intraepithelial neoplasia. Let me know if there are any type of questions on this subject. If not, we can continue to the next vignette. Okay, thank you, Megan, for confirmation. All is good. Now, we have a 25-year-old that presents with an acute myocardial infarction in the emergency department. After risk management, extensive lab work is conducted to identify the underlying etiology. On labs, we have the cholesterol that turns out to be 850 milligrams per deciliter. What other features of this patient's disease are seen? Corneal arcus, abdominal pain radiating to back, creamy layer in the supernatant, or hepatosplenomegaly? Please vote in the poll. So we have hypertriglyceridemia and start statins. Interesting. Okay, let's see the results. So we have 3 votes for two votes for corneal arcus and 1 vote for abdominal pain radiating to the back. Okay, now let's discuss the answers. So the correct answer is actually corneal arcus. The patient has type 2 familial dyslipidemia, namely hypercholesterolemias, familial hypercholesterolemias. On the other hand, abdominal pain that radiates to back corresponds to pancreatitis. Indeed, this is typical for hypertriglyceridemia, which is a type 4 familial dyslipidemia. A creamy layer in supernatant corresponds to type 1 dyslipidemia. This is represented by hyperchylomicronemia, and also hepatosplenomegaly is caused by buildup of chylomicrons in the liver. The correct answer, as we talked before, is A. The patient has type 2 familial dyslipidemia, hypercholesterolemia. Pancreatitis is seen in either type 1 familial dyslipidemia, hyperchylomicronemia, or in type 4 hypertriglyceridemia. A creamy layer in the supernatant is given by high levels of chylomicrons, type 1. Okay, in the chat, Dr. Deepa tells us that it is lipid deposition. It is present because of old age too. AAA. Dr. Deepak, do you have a more precise question? Okay. So indeed, there is the question of a corneal arcus that is also called a senile arcus. This is a different type of arcus that appears with old age, also due to lipid deposition. On the other hand, the patient is not a candidate for an aortic abdominal aneurysm, as he's too young. We suspect, and actually we screen patients for aortic abdominal aneurysms if they are more than 50 years old, actually if they are between 60 and 75 years old, and they have a status of smoker, due to the fact that they have an increased risk of developing this AAA. The screening is done with an ultrasound. Okay, let's recap a bit the type of dyslipidemias. So we have type 1 dyslipidemia, familial dyslipidemia, hyperchylomicronemia. This is a creamy layer in supernatant. It presents with hepatosplenomegaly, pancreatitis, and pruritic sanctomas. On the other hand, we have type 2 familial dyslipidemia, which is hypercholesterolemia. It presents with precocious myocardial infarction even before 20 years old, with corneal arcus, with an Achillean or a tendon xanthoma. In comparison, type 3 dysbeta-lipoproteinemia presents also with precocious myocardial infarction, but with tuboeruptive and palmar xanthomas. Finally, type 4 hypertriglyceridemia is presenting usually with insulin resistant and pancreatitis. Now, for a little bit of a break, we have to think about the types of hypercholesterolemia. Could you tell me how many types of hypercholesterolemia are there? So Lucas tells us that there are 6 or 5. Could you tell us what types of familial Yes, exactly. So this is the answer that I was looking for. Type 2 has 2 subtypes. It is a homozygotic one and a heterozygotic one. We can differentiate between homozygotic and heterozygotic one through the level of cholesterol. Namely, if the cholesterol is beyond 300 milligrams per deciliter, then we have a heterozygote patient. If the cholesterol is about 600 or 700 milligrams per deciliter, then we consider that the patient is a homozygote one. Usually, the homozygote type is very rare, while the heterozygote one is more common. Please, Megan, Lucas, Deepak, and Kainat, let me know if there are any questions on the topic of familial dyslipidemias. Indeed, Dr. Deepak, you are right. Per USPTF recommendations, the screening is between 65 and 75 for aortic abdominal aneurysm. Okay, so we are all good. Now, for a little break, if you want to check out the cardiology live stream, I'll let the link in the chat box. It is a more extensive live stream on cardiology. Also, if you want to receive a weekly newsletter, which contains summary sheets for both NBMEs and for your clinical rotations, send an email to medicalperspectiveblog@gmail.com. Now, please let me know when you are ready to go for the next vignette. Okay, let's do a little roundup to see who's on before continuing. Megan, Dr. Deepak, Lucas, and Kainat, please confirm in chat if you're still on, so we could go further. Okay, I see you are all excited, so this is really good. We have a 53-year-old woman that presents after identifying a breast mass of 3 centimeters. It is fixed and under the areola. An axillary lymph node is fixed and immobile ipsilaterally. The mammography confirms a calcified mass, locally invasive. The estrogen receptor progesterone receptor profile is negative. What is the best next step? Mastectomy with irradiation, neoadjuvant chemotherapy and trastuzumab, tamoxifen, or lumpectomy with irradiation? Okay, we will finish the question poll in 3, 2, 1. We are done. Let us see the results. So we have 2 of you that say that we go with mastectomy with irradiation, and 1 of you said that we do a lumpectomy with irradiation. So before considering a treatment option, we have to establish what this type of cancer it is. It is an early cancer. Well, as we see, it is already fixed, and already we have an N2 or N3, an N1 or N2 on the TNM staging, due to the fact that the axillary lymph node is fixed and immobile. Also, we have the information that the patient has a locally invasive, so it's not an early tumor, nor it is metastatic. However, it is locally invasive. So normally in an early presentation we can consider lumpectomy with irradiation. It is true that for locally invasive tumors we use mastectomy with irradiation. However, when we have a locally invasive tumor, we firstly need to reduce its mass. We are doing this by administering neoadjuvant chemotherapy and trastuzumab. Then we follow up with mastectomy and radiotherapy, and finally we go for a neoadjuvant chemotherapy again, but this time we go with estrogen receptor and progesterone receptor medication. In this patient's case, we do not have such an option. So, for locally invasive tumor, we treat it in first place with trastuzumab and neoadjuvant chemotherapy to decrease its size. This is why the answer is B. Afterwards, indeed, we proceed with A, namely a mastectomy, and we perform a sentinel lymph node biopsy. Finally, we add adjuvant chemotherapy, as we talked about. If we have a positive estrogen receptor or positive progesterone receptor, we go for a selective estrogen receptor modulator, such as tamoxifen, or aromatase inhibitor. However, pay attention in the question stem that the patient is postmenopausal if you give her an aromatase inhibitor. Lastly, if the patient has a HER2 positive tumor, then we give trastuzumab. Before going for a recap, let's discuss a bit what is the most important side effect of trastuzumab. Please let me know the answer in the chat. So Lucas asks us if we can look at the options one more time, and also Dr. Deepak told us that breast conserving surgery would be a good option. We will discuss immediately why breast conserving surgery is not an option in this case. Yes, indeed, the HER2 receptor status was not mentioned. Here is the answer. The question again. So we have reversible dilated cardiomyopathy, exactly. And also that one should do echo before starting trastuzumab, exactly. This is really important to pay attention when we give to a patient trastuzumab. We have to pay attention to dilated cardiomyopathy and to its ejection fraction. Indeed, Lucas has a point. If we don't know HER2 receptor status, how can we use trastuzumab? The idea in the question was to test what are the steps chronologically in treating any type of locally invasive tumor. We could add that the patient is HER2 positive. Okay, now let's recap a bit. How do we treat every type of breast tumor? And then we can answer the question from Dr. Deepak, namely why we do not use a locally conservative method in this patient. So the treatment in breast tumors, if we have an early stage, we do lumpectomy plus radiotherapy, or we can do mastectomy plus radiotherapy, and we always follow up with an axillary lymph node biopsy for staging. As we discussed previously, in locally invasive tumors, we do chemotherapy and trastuzumab to decrease its size, and it's not necessarily that the patient has to be HER2 or ER or PR positive. We can use actually chemotherapy to decrease its size irrespective of its receptors. This is actually the way we treat metastatic disease. Metastatic disease, as we can see below, we treat it with chemotherapy and radiotherapy, even if it's triple negative, and we know that triple negative metastatic disease, such as ER, PR, and HER2 negative, has very poor prognosis, and we actually start chemotherapy with platinum-derived compounds, even if the tumor has more than 0.5 centimeters. Coming back to metastatic disease, we give her chemotherapy and radiotherapy, and we consider mastectomy just for the symptom control. As for the locally invasive, there's a triple sequence. Chemotherapy with trastuzumab, we decrease its size, then we go for mastectomy and radiotherapy, and lastly, axillary lymph node biopsy. At the end, we can add the adjuvant therapy, which indeed is always hormone-dependent therapy or HER2-dependent therapy, namely ER, PR, or HER2. Now, let's answer the question of why don't we do a lumpectomy? Let's say that we could have done a lumpectomy. In the question stem, it is stated that it is not stated. Yes, it is stated that it is fixed and under the areola. This is very important because if we have an early stage tumor, the question is how do we treat it, with lumpectomy or mastectomy? Now, what are the contraindications for lumpectomy? If we have a tumor under the areola, as in this case, we do not perform lumpectomy. Even if it's early stage, we go to mastectomy. If the tumor has a large size, above 2-5 centimeters, even 2-5 centimeters, which will stage it in the T2 class. If the tumor is multifocal, meaning that we have multiple determinations on the same breast. If the tumor is fixated to the chest, as in this case, so we couldn't do a lumpectomy. If the patient had prior radiation to the chest wall, so for example, if we did a lumpectomy for a previous tumor and the patient presents again with a tumoral mass and we treated previously with lumpectomy and radiotherapy, then we cannot do another lumpectomy. And lastly, if we have involvement of the nipple, then always mastectomy, even if the patient has an early stage tumor. Please let me know if you have any questions. I will answer them. As Lucas pointed out about the chemotherapy in the beginning, so the idea was that the chemotherapy in the beginning is not always a chemotherapy that is dependent on the receptor positivity and HER2 positivity. It can also be chemotherapy on platinum-based alkylating agents. Okay, let me know if you have any questions. Dr. Deepak, Megan, Kainat, Lucas, do you have any questions? Okay, then I'm glad that you were today. If you like this type of content, please subscribe. You can also see similar content on this YouTube channel. Subscribe and also recommend to other people that are in this Step to CK journey. If you haven't completed the feedback form, please consider completing it. This way I can understand how to better create courses for you. And lastly, please let me know any topics you have difficulties with in the chat box so that we can have them on the Reddit poll next time. Okay, so Dr. Deepak says psychiatry. If you want to take a look at our previous live stream, which was exactly on psychiatry, you can take a look. This was for today. The next live stream will be on the 21st May. So make sure you are subscribed and that you hit the get reminded button of the next live stream that will stream on the 21st May. Thank you, Dr. Deepak, for being present. Thank you, Lucas, for being present. Thank you, Megan, for being present and for taking part to this course. I hope we can see each other on the 21st May. And also, I hope that we can also see with Kynat. I don't know if she's still on. Hi, Kynat. Okay. Thank you also. So, have a nice day and see you on 21st.